All right. Good morning, everybody. Thank you for joining us for our webinar hosted by the NHMRC Centre of Research Excellence on Achieving the Tobacco Endgame. I'm Danielle and I'm a research fellow in the centre. Today, we're lucky to be joined by Dr. Alys Havard and Dr. Danielle Tran from the National Drug and Alcohol Research Centre, NDARC, at UNSW in Sydney. They will be presenting the results of their very recently completed multinational study of the use, safety, and effectiveness of smoking cessation pharmacotherapy during pregnancy. I was lucky enough to see a sneak peek of some of these results at the NDARC Symposium a few weeks ago in Sydney, and they were absolutely fascinating, so I'm really looking forward to hearing more. Before we begin, I'd like to acknowledge the traditional owners of the unceded lands that we meet on today. For me, it's the lands of the Yagara and Turrbal people, and pay my respects to their elders past and present. Now I'd like to introduce our two speakers. Dr. Alys Havard is a senior research fellow based at both NDARC and the School of Population Health at UNSW in Sydney. She's also a deputy director at NDARC. Dr. Havard's research uses large-scale linked data to study the use and effects of prescribed medications in priority populations, such as pregnant women and people with cardiovascular disease. Dr. Danielle Tran is a research fellow also at NDARC in Sydney. Her research areas include the utilization of medicines, health services, and health outcomes, leveraging big data in real-world settings. All right, over to you, Alys and Danielle.
Thank you, Chanel, for that lovely welcome. I will just get my screen share going. Okay. Hopefully that's all good.
Perfect.
Okay. So hi everyone, and thanks for joining today. It's really nice to have your interest in hearing about this research, which is a program really of research on the use, effectiveness, and safety of smoking cessation pharmacotherapies during pregnancy. For those of you who don't know me, I'm Alys Havard, and I lead this program of research, and I'm CIA on the NHMRC Idea grant that funds the work. I'm presenting alongside my colleague Danielle Tran. Danielle is leading the studies on focused on the safety of these medicines during pregnancy. Of course, it's not just Danielle and I. There's a whole team of collaborators generously contributing to this work, including those based in the countries contributing data to the study, and they are listed here on the slide. So the plan for our presentation today is for me to kick off with an overview on why this research is needed, the range of studies that we're planning to conduct, and a quick look into what we found in relation to the number of women using these medicines during pregnancy. And then I'll be handing over to Danielle, who's going to give us a deep dive into one of the safety studies and then to talk about what comes next. So I'll start with some background on why women who are pregnant might choose to use a smoking cessation pharmacotherapy. First, smoking is a leading cause of negative pregnancy outcomes. It's a well-established cause of low birth weight, preterm birth, stillbirth, sudden unexpected infant death, among a range of other severe harms. And second, smoking in pregnancy is still relatively common, with almost 1 in 10 women in Australia smoking when pregnant. Although the associated harms can be reduced by quitting early in pregnancy, under current practice, only 1 in 4 women who smoke succeed with quitting before the second half of pregnancy. And it's also important to note that the burden from smoking during pregnancy is not evenly distributed across the population, with women in disadvantaged groups more likely to smoke more heavily, and to be less likely to quit. So given this burden, there's a clear need for strategies that help women to quit. Smoking cessation pharmacotherapies are an appealing candidate because outside of pregnancy, they've been shown to be the most effective strategy for promoting quitting. When I talk about smoking cessation pharmacotherapies, I'm referring to the 3 pharmaceutical products that are registered for use as smoking cessation aids in Australia and most other developed countries. These include varenicline, nicotine replacement therapy, and bupropion. Varenicline and bupropion are prescription-only medicines and are subsidised in Australia and the other countries participating in this research. Nicotine replacement therapy is available on prescription and over the counter in all of the countries participating. A barrier to the use of these medicines during pregnancy is that we don't know whether they're safe to use during pregnancy. So because of this, clinical guidelines recommend against the use of varenicline and bupropion during pregnancy. Most clinical guidelines state that nicotine replacement therapy can be used during pregnancy if the expected benefits outweigh the risk of harm. But this isn't to say that nicotine replacement therapy has been demonstrated to be safe during pregnancy. The evidence on this is actually not clear-cut, but its use during pregnancy is generally supported on the assumption that it's unlikely to be more harmful than continued smoking during pregnancy. The main reason for the inadequate evidence on the safety of these medicines during pregnancy is that pregnant women are typically excluded from clinical trials for both ethical and medico-legal reasons. There have been trials done in relation to nicotine replacement therapy, but generally they've been too small to provide conclusive evidence on the risk of severe but rare outcomes like congenital malformations in the children. Clinical trials have also not been able to resolve the question of effectiveness during pregnancy. In these circumstances, we need to rely on evidence from observational studies. And there have been a handful of observational studies conducted on these medicines during pregnancy, and they've produced promising results regarding some of the more common safety endpoints, but they still haven't been large enough to provide conclusive evidence around the risk of congenital malformations in infants or on the effectiveness of these medicines during pregnancy. So that's what we set out to do, to conduct the largest observational study of the effectiveness and safety of smoking cessation pharmacotherapies during pregnancy to date. As a first step, we quantified how many women were using these medicines during pregnancy, and I'll be showing you those numbers shortly. In relation to effectiveness, we're planning to examine the rate of quitting among women using these medicines during pregnancy compared to those who smoke but don't use one of these pharmacotherapies. And we're also planning to compare the rate of quitting between women using different types of pharmacotherapy during pregnancy. When it comes to safety, we're planning to examine a range of different outcomes. First up, we've looked at the risk of congenital malformations or birth defects in infants born to women using these medicines during pregnancy. And these are the results that Danielle will be presenting today. In the second safety study, we'll be looking at a range of maternal and neonatal outcomes that are typical endpoints in medicine safety studies during pregnancy. So they include things like preterm birth, postpartum hemorrhage, and poor fetal growth. And then in the third safety study, we'll be examining the impact on childhood neurodevelopment. So specifically the risk of ADHD and autism, as well as academic performance using NAPLAN scores. So we are addressing these aims using linked data from 4 countries. These include Australia, where our data is restricted to New South Wales, New Zealand, Norway, and Sweden. In each of the participating countries, we have collaborators who hold data sets containing information for the whole population of women who gave birth over the last 20 years, as well as information on the children of these women. These data sets are constructed by linking together information that is routinely collected through contacts with the health system and other government services. So for each woman, we have perinatal records, which include information for all pregnancies that resulted in birth. These records are quite detailed and contain information on the sociodemographic characteristics of the mother, health information, including whether she smoked during pregnancy, at the various stages of pregnancy, and how much, and lots of information about the childbirth and the health of the neonate. Linked to these perinatal records, we have hospital admission records for the woman, death records if they exist, and importantly, records of any prescription medicines she may have been dispensed. And we have similar information for the babies. So in addition to the health services data for children, we also have the results of NAPLAN tests, which I mentioned before, and this will be key to understanding the impact of prenatal use of these medicines on academic performance. So that's a quick look at the whole program. I'm now going to briefly cover what we found around how many women are using these pharmacotherapies during pregnancy. So this utilisation study is being led by Alys, who is a postdoctoral fellow in our research team here at NDARC, and she's currently writing these results up for publication. The first aim was to determine the proportion of pregnant women using each of the smoking pharmacotherapies while pregnant. And we calculated this as a proportion of all pregnancies, as this gives us a sense of the number of women who would be impacted if these medicines are found to be unsafe or carry risks during pregnancy. And we also calculated the proportion of women recorded as smokers using these medicines, because these are the women for whom the medicines are indicated. We focused on births between 2015 and 2019 in Australia and Sweden, and we had an extra year of data up to 2020 in New Zealand and Norway. To identify which women used a pharmacotherapy, we took the dates from the prescription medicine dispensing records and lined these up against the dates from the perinatal record. We considered a woman to have used a pharmacotherapy during pregnancy when there was a dispensing between the date of conception and the date of childbirth, or when the women were dispensed a pharmacotherapy shortly before pregnancy, where the amount supplied was expected to last into the gestation period. Altogether, we included 1.7 million pregnancies across the 4 countries. The proportion of women smoking during pregnancy varied quite a bit across jurisdictions, being the highest in New Zealand and then New South Wales and then the Nordic countries. Looking at the prevalence estimates for varenicline first, and I will also look at bupropion at the same time. Both of these, we can see that the use is really quite low. It's only a fraction of a % of pregnancies across all jurisdictions. In contrast, the prevalence of nicotine replacement therapy use varied quite a bit between countries. Almost 2% of pregnant women in New Zealand used NRT, prescription NRT, while in other countries, it's only a fraction of a %. And we suspect that the fact that nicotine is available over the counter, as well as on prescription, is playing into these low estimates and also the variation between jurisdictions. But we know there's minimal use of over-the-counter nicotine in New Zealand because the out-of-pocket costs for prescription nicotine are really low. So, and also we know that in New Zealand, all formulations are subsidised. So we think that the estimate for New Zealand is pretty robust. The estimates for New South Wales, Norway and Sweden are probably quite underestimating the total use of nicotine during pregnancy. Overall, the use of these medicines among pregnant women appears to be pretty uncommon, which is encouraging, while the safety of these medicines is not yet clear. When we looked specifically at women who smoked during pregnancy, the prevalence of use was between 5 and 10 times higher than those estimates in the table. This still equates to pretty low use of varenicline and bupropion. But for nicotine replacement therapy, it's getting as high as 10% among maternal smokers in New Zealand. As a second aim, we were interested to know the extent to which women use these medicines in the first trimester of pregnancy, because this is the period when the fetus is at risk of developing congenital malformations. For this aim, we again used the dates from the prescription medicine dispensing records, but we focused on dispensings that occurred before the end of the first trimester. We found that among women who were using nicotine replacement therapy, about 60% had some use in the first trimester. And for varenicline, it was 94% or more had some use in the first trimester. We couldn't do this analysis for bupropion because the use was too limited. But these results really highlight how important it is to understand whether the use of these pharmacotherapies during pregnancy or during the first trimester carry a risk of congenital malformations in babies. Okay, I'm going to hand over to you now, Danielle.
Thank Thank you, Alys, and hi, everyone. So it's my pleasure to be here today. And in the next 10 minutes or so, I would like to talk about some work that we have been doing regarding the examining the risks of congenital malformation in infants exposed to these 3 pharmacotherapies in pregnancy. Can you go to the next slide? Yeah. And in terms of methodology of our work, so when we design the study, we keep in mind that smoking itself is a risk factor for congenital malformation. Therefore, we included in our study population women who smoke in early pregnancy, so they will take away potential mediating effects of smoking on the relationship between exposure to medications and malformation outcome. So in terms of exposed group, we define exposed group as the pregnancies of women who had a dispensing of smoking cessation pharmacotherapy within 90 days before date of conception, and the duration of supply lasts into the gestation period. And we measure exposure to NRT, varenicline, and bupropion separately. On the other side, the comparison groups included pregnancy of women who did not have any dispensing of this therapy in the window between 90 days before conception and the end of the first trimester. So in both groups, we selected singleton live birth, and we use a propensity score technique to match those exposed to the unexposed pregnancy. So I will talk about the propensity score matching a little bit later. And when we move on to the outcome, we follow children up until 18 months of birth. We search in the records of inpatient data, outpatient data, and even in the death records to identify diagnosis of major congenital malformation. We excluded malformation that were due to genetic disorders or due to viral infection. So we classify our outcome into overall malformation, and according to 13 body systems that we listed on this screen here. And we also interested in some specific condition of several body systems. We follow the classification by the European Surveillance of Congenital Anomalies to classify our outcome. And for New South Wales and New Zealand data, we also adopt recommendation from a study conducted by the New South Wales Department of Health, in particular when we define the malformations such as undescended testes and clubfoot. We require the presence of procedure code for these anomalies. So for the interest of time today, so I would like to just focus on the result that we have so far of the malformation overall and at the body level system. So move on the another part about the method. So we are conducting an observational study. So in the absence of randomization, we were very, very careful about the confounding effects, because women self-selected to use pharmacotherapies. They were likely to differ from those who did not use pharmacotherapy. There may be differences in their socioeconomic status, in health status, and experience of prior pregnancy adversity. Such differences may contribute to the risk of having a baby with a congenital malformation. So we come up with a list of all the potential important factors that we listed in the word cloud on the slides here. So we have a range of variable denoting women's socio-demographic characteristics, such as age, indigenous status, country of birth, marital status. And in terms of obstetric characteristics, we use parity and whether a woman had an older child was affected by a malformation. We created multiple variables to capture maternal health status and morbidities, such as mental health, chronic respiratory conditions, cardiovascular disease, hypertension, diabetes, epilepsy, as well as the number of hospitalization in the 12 months prior to conception. We excluded women who use medicine that we know that they can cause malformation or potentially cause malformation. We also excluded women who had infection with certain virus that can cause malformation in the period leading to the conception. And then we use the propensity score technique. So I just want to a little bit highlight on the propensity score. So it is a probability of for a woman receiving a pharmacotherapy treatment given their characteristics. So after we calculate the propensity score for each woman for each pregnancy, we match exposed pregnancy with the unexposed pregnancy based on the similarity of their propensity scores, as well as they have the same, they deliver the baby on the same year of on the same calendar year. So we do we match 1 exposed to up to 10 unexposed pregnancy. So with this method, we want to make sure that the exposed and then the unexposed group, they achieve a balance into potentially confounding factors. After we done all that, so we calculated the prevalence of malformation per 1,000 live birth. We calculated rate ratio with 95% confidence interval, and we using meta-analysis to pull results across 4 jurisdictions that contributing data to the study. So here is the result. This is the result for nicotine replacement therapy. So we had data from New Zealand and New South Wales. In Nordic country, in Norway and Sweden, most NRT products were available through over the counter. So we found only a handful of women had the prescription of NRT. So that's why we only restrict our analysis to data of from New Zealand and New South Wales. So for the period from 2007 and 2019, we had together about 9,325 pregnancy exposed to the NE products of NRT in the first trimester. So on the table here, we show the numbers of children having a malformation overall and for each body system. The prevalence is we're showing in the bracket, which is the prevalence per 1,000 live births. So the forest plots on the right-hand side is another way to visualize the rate ratio. So the rate ratio are represented by the dots, and the horizontal line represent the 95% confidence interval, which indicate how precise the risk estimate is. With the rate ratio greater than 1 indicate pharmacotherapy associated with the increased risk of malformation, while the rate ratio less than 1 indicating lower risk of malformation. And I just want to also note that the red dots represent the result of meta-analysis, and then the blue dot represent the result from a single country. So we have for some for New South Wales data, we don't have the great number to go down to a level to body level system for number of body level system malformation. So we were able to meta-analysis for only overall malformation, cardiac system, and the limb system. So now we can see that for NRT, there is no increased risk of malformation overall, from malformation of the heart, the limb, and genital organs and renal system. With the exception is the malformation for digestive system, so which we see 50% more likely among baby born to women using nicotine replacement therapy. But I would like to note here that the absolute risk difference is quite small. So the difference is just around 1.3 child per 1,000 births. And when we go down the forest plot, there also look like there could be an increased risk of malformation of the eye, but eye formations are very rare. The confidence interval is very, very wide. So this is the result for varenicline, where we had data from all 4 countries from 2008 to 2019. We had altogether around 3,000 exposed pregnancy. The first thing that I would like to note here is that the risk of children experience any type of major malformation is very close to 1. So we can conclude that varenicline does not increase the risk of malformation overall. When we running our eye down the plot, we can draw a similar conclusion about the risk of malformation for the heart, limb, genital organs. And when we look at the risks for kidney and urinary tract, we looks like the rate ratio is double among the exposed children, while the association might be true, but it could be due to the finding grows by chance, and given that we have a lot of more statistical tests. And then also I would like to note that this is based on only 11 exposed children and 40 unexposed children. So very small number of children were affected. For other body systems such as digestive system, respiratory system, cleft, the number of exposed baby having outcome were very small. We were unable to calculate the risk estimate, or risk estimate for those are very, very imprecise. Looking at bupropion now, so we pull data from 2 countries, New Zealand and New South Wales from 2002 and 2019. We had about 1,000 exposed pregnancy. There is again no increased risk of malformation overall, and the risks of malformation for other body system are very, very imprecise, or we were not able to calculate risk estimate at all because of the low use of bupropion. So altogether, what do the data tell us? Our study is the largest observational cohort study to date, which allows us to examine the risks of malformation at deeper details than previous NRT trials and other observational studies. Quitting smoking has a great benefits for mothers and babies. Smoking cessation pharmacotherapy are effective strategy for smoking cessation. And our data suggests that NRT is unlikely to increase the risk of malformation overall and for most common body systems, with the exception that there's an increased risk of digestive system malformation, although this impacted a very small number of babies. But it might be worthwhile to examine this further in future study, given that the possibility of finding arose by chance. And moving on to varenicline, our result about vareniclines are encouraging, although we were not able to detect the risks for some outcome precisely. Among 3 therapies, so we know that varenicline has demonstrated the most effective. In our prior work in pregnant population, we found that varenicline is more effective than NRT, and it does not increase the risks of adverse birth outcomes. Clinical for varenicline might be now possible, given the evidence about its safety. And if confirmed by clinical trials, smoking women would have more option than for smoking cessation, just rather than just NRT. And bupropion is a less popular choice for smoking cessation. Overall, safety around malformation is also promising, although we need a bigger study to confirm some of the results that we presented here. Just moving on our limitation. First, we although we did compile data from 4 different countries, the number of women in our study was still too small to examine all malformation categories. And the second limitation is that because our data based on CNEOs were restricted on the dispensing prescription medicines, some of the women in our unexposed group may have in fact used nicotine replacement therapy that they purchased over the counter. However, the estimates of utilization during pregnancy that Alys showed you before, those estimates suggest that the proportion of nicotine replacement therapy used over the counter would be very small. And the third limitation that we keep in mind is that our exposed and unexposed group only include pregnancy that resulted in a birth. Because these are the only pregnancy that we had information for in the perinatal data in all countries. By excluding pregnancy that resulted in miscarriage or termination, we may have introduced some selection bias, especially if pregnancy exposed to smoking cessation pharmacotherapy are more likely to result in early loss or termination. So we plan to explore the potential effect of this in further analysis, in the further sensitivity analysis. And the last point that we want to point out is that we use prescription dispensing data. We don't have the data on actual use of medication or how long women use the medicine for. So that means that we may have overestimated the number of women who were exposed during the first trimester of pregnancy. We're going to be conducting sensitivity analysis to address some potential impact of this. For example, we're going to restrict some exposure pregnancy to those who have multiple dispensing, and with one of those dispensing occur in the first trimester. So yes, that is the few limitations that we want to talk about. And so what is the next in our plan? So we are currently writing up manuscript for findings from the utilization and the malformation studies. We aim to submit to journal early next year. Then we will proceed with the study to examine the effectiveness of this medicine when they are used in the pregnancy. In particular, we will compare the rate of quitting smoking between women who use a smoking cessation pharmacotherapy during pregnancy and those who do not use. And then we will also compare the outcomes between women who use different therapies, and then comparing the quitting outcome between those who use, for example, comparing the quitting outcome between varenicline with NRT. Previously, we had published with the result comparing effectiveness of varenicline versus NRT. However, in that study, we had only data for NRT subsidized for only 2 years, so we were only able to include about 60 women in each comparison group. So in this multinational collaboration study, we will have a bigger study samples, allowing us to generate more precise estimates around effectiveness. Following the effectiveness study, we will examine pregnancy complications and birth outcomes, such as stillbirth, birth weight, neonatal mortality, and some other outcome as well. We have reported this outcome previously, but the study power was not too great, especially for bupropion and NRT. So in the upcoming study, we will also consider the role of bupropion and NRT in the bigger study sample. And we also consider the role of quitting, whether women who use the medicine and quit have a better outcome than women who use medicine but were not successful with quitting. And another piece of analysis that we plan is also the long-term child development outcome. We will conduct a study to focus on the neurodevelopment outcome, including the incidence of ADHD and then academic performance using academic result tests that we have with children for children in our cohort. Before we open up the section for questions, so we would like to acknowledge numbers of organizations for providing access to the data, for linking the health records, for funding to conduct the study, and also for some other funding sources. This project would not be possible without the support. So if you also would like to know more about our study, so Alys' email address and my email address is on the slide. So thank you all for joining the webinar today.
Great, thank you so much, both of you. That's absolutely fascinating. All right, audience members, please share your questions for Alys and Danielle in the chat box. I'll start by asking, so I'm still learning a lot about policy implementation, and our research finds one thing, but policy often follows something else. And so your results are quite innovative and interesting, and it's really got strong implications for policy. And I was just wondering if you could speak a bit about how you think that process is going to go in the future, kind of changing the practice around this very sensitive topic.
I think you've hit the nail on the head there around sensitivity.
Yeah,
it's hard, Danielle flagged, it's particularly around the results for malformations that even though we've potentially found some risk, they're potentially by chance, they're small risks. You don't want to put a message out there that there are increased harms, yet this is what the data is showing. So we're still working on exactly how to pitch that message. I mean, I think another consideration for us is around the fact that we're using observational evidence, evidence from observational studies, and often, policymakers, clinicians would want to see RCT evidence to really be sure. Unfortunately, in this space, it's really unlikely. Even as we've said, now maybe clinical trials are possible because we have some reassurance around the safety. It's still, even if that does happen, how are we ever going to get a large enough clinical trial to measure the risk of malformations? We've had 9,000 exposed pregnancies in terms of NRT here. How is that going to happen in clinical trials? So it kind of leaves us in this spot of, are we ever going to get any stronger evidence? So, I mean, I guess there's some of the challenges. I know that wasn't exactly your question.
No, but it's a great one. Yeah,
I mean, it's something we obviously have to consider when we are talking to policymakers about it. I am in the process of setting up some meetings with the TGA, and I guess from there we'll see what their take is on the size of the risks we found, I suppose, and also the type of evidence that it is.
Yes, absolutely. Oh, well, I'll be watching the process with interest, because as you say, how on earth can you create RCT evidence on this topic? Yeah. No, that is interesting. All right, do we have any questions from the audience? You can either post them in the chat or just unmute yourself. So how far are you with the next stages, and are you planning to publish the results that you already have, or are you waiting until you've got the rest of your results before you publish?
Oh, we're definitely keen to publish what we've got so far. So in the process of writing up both the utilization results and the malformations pieces separately. And we've made a start already on the effectiveness study. So we've got, the grant period is until the end of 2025. So we've got a bit more time to do it. But obviously, I personally think there's an urgency for this evidence. So the sooner the better, really. Yeah, no, I completely agree. I know that in Queensland, they were really pushing the quit smoking, what's it called? Intensive quit support program for people who are pregnant, which provides 12 weeks of free NRT and weekly quit line calls. And that was the one priority population they were really focusing their efforts on. And I thought absolutely worth it. Yeah, no, definitely. I completely agree. It's a priority. Yeah, you've raised a good point there, though, that it's not, I talked about the TGA in response to your question around policy, but there's many other service providers and that are probably dealing with this question daily, and I guess we need to work out a strategy for engaging yeah, all the different bodies that need this evidence.
Yeah, absolutely. Yes. All right, final call for questions from the audience. Anyone? All right. I think your presentation was just so comprehensive that you've answered every question that anyone might have.
Can I put a question back to you, Chanel, around what would you do to facilitate the translation of findings into policy?
That is a great question. It's something I'm still learning so much about. It's such a new area for me. I've, my PhD, I had very clear recommendations on helping people who've been in prison to quit smoking, and they were obviously completely ignored because of there's a whole lot of wider contextual policy implications, and yeah, they all have their own, like, this guy's job is just to implement the ban, and then this guy's job is just to make sure they don't get back into prison, and there's just this gap in the middle, and I'm still flummoxed as to how you would address something like that. So yeah. But I think meeting with the TGA is a really good first step. I think that's absolutely the first place to start. And something that we're working on at the moment is policy briefs. So really clear, simple, basic evidence summaries that are really nicely formatted, and you get the three most important things you need to know on the front page. So we're still working on those, but I'm really interested to see how those will go. So yeah, if they're successful, maybe we can have a chat about that.
Yeah, sounds great. Yeah, always looking for good ways to communicate our messages.
Yes. All right, we have a question from Belinda. Really interesting to see such data. If you were able to consider an RCT and able to get through ethics, etc., you would probably need to choose one pharmacotherapy strategy for sufficient power. Which would you choose and why?
Good question, Belinda. Danielle, do you want to have a crack at this, and I'll chime in if need be?
Yes, thanks, Belinda. That is great questions and very much eye-opening for me because I'm coming from the non-RCT background, and but we have this NRT clinical trial going on already, and varenicline and bupropion, that there haven't been any clinical trial at all. But I'm thinking in terms of the risk benefit. So between these the benefits between the balance between the effectiveness and outcome and the safety. So I'm just thinking around, if I can have a wish, I would go for varenicline first, given this is quite, it is, we have reassuring data on safety and also on their effectiveness. So if women have a option, strong option to help them to quit, and then safe option, so that is my thinking. Thanks so much. Do you have anything to add, Alys?
Well, I think I agree. I mean, I have two preferences out of three, which is pretty much hedging my bets. But I agree that I think we need the evidence more for varenicline. NRT is it's already in practice, and we also know that the evidence around its effectiveness is not great. During pregnancy, and I think that's mostly around the metabolism being different during pregnancy. So there is sort of a need for another option. But on the other hand, for practical reasons, I'd say NRT, because there have been some trials already, and we could, if you did a trial and were able to get sufficient numbers to some extent, you could at least pull your results with that prior work and hopefully come to a more robust estimate. So I think the practical choice would be NRT, but the need, I think, is greater for varenicline. Good question.
Good question and great answers. Ara said, thank you for all your great presentation. I think it is a very important study to have more evidence for pregnant women. I might miss this in the background, but I'm wondering why you chose 2 Nordic countries.
That was practical reasons. We've worked with those 2 countries before. We've actually worked with all 5 Nordic countries in other linked data medicines in pregnancy research. And so we've had an established collaboration. We know our data is fairly similar, so it's reasonable to pull the results. And the 2 Nordic countries that actually ended up in this study, it was around their data agreements being able to use their data to study this question when they had existing approvals that the other countries had existing approvals that limited what they could use the data for. So it was, around prior partnerships and practicalities.
Makes sense. All right. Do we have any final questions from the audience? Oh, we do. Is there animal data that supports the increase in malformations in the systems you reported?
It's a good question, Belinda.
Yes, it is great. Yes, I think there's some literature around animal study around NRT and neural development in the mice. I think that is what I have been finding so far, but not yet successful finding the animal study that reporting the digestive system in animals.
I suppose animal studies often aren't that big either.
Yeah.
Just the rare outcome factor.
Yep, absolutely. All right. Well, thank you both very much for your time and for sharing your very interesting results with us. Very important topic and super interesting. And I know all of us are going to be very interested to see more results as they come out.
Thanks for the opportunity. I mean, we obviously think this stuff is important. We're keen to test it with an audience, see what everyone's reactions and questions are. So it's been really helpful for us.
Great.
And great to get some exposure for it.
Excellent.
Thank you.
All right. Thank you, everyone, for joining us.